doing this occult blood, okay, how we would do that test. If I had stool in this bedpan, okay, remember I told you we would get it from the middle of it, because if they had fissures or hemorrhoids, they could have blood. We expect blood to be on both ends. All right, so this has, this has directions on the card for you, okay? It says, put a small thin smear of stool on each square. This is your applicator. You take it from the middle, put a thin square, okay, and a thin little smear, and we seal this up, throw this away, okay? You'll get it in the doctor's office like that. That's how much stool they'll put on there, okay? We just need a thin little slice. We're going to flip this over, open it. This is where we're going to apply our reagent, okay, or control. All right, we're going to put 2 drops on each square. But before that, every one of your tests has a control. So I'll drop a little on the control to make sure this card is still working. Y'all see that little blue dot? That means it's working. That's what color it should turn if it is positive for blood, okay? So then I'm going to drop my 2 drops onto each square. Drop, drop. And I'm going to wait how long? Do not read it after a minute, okay? Stand there and count your minute and read it. It should be blue. You know, most of the time if there's blood, it's all blue. But even if it just has a halo of blue around the square, that means it's positive, okay? In the real world, you won't just go by one. You'll test at least 2 stools on two different bowel movements on 2 different days. Blake, will you shut the door for me? Okay? So when y'all give instructions to your patients, and you will, make sure you tell them a thin smear, okay? And give them all the supplies they need, and tell them when to turn it back into you, okay? Okay. Now I'm going to talk to y'all about, let me start with your supplies, okay? This is how it comes. This is how all our enema bags come if you're going to give a soap sud enema that's 1,000 cc. That means we fill it all the way up with really warm water, the same temperature that we would use if we were given a bed bath, okay? It comes with this little packet. Y'all see this packet? That's your little mild Castile soap. This little tiny package goes into this water, okay? So we would go over to the sink in the patient's room and fill that with warm water. I'm going to show you how it opens. There's a little pocket here in the top. We hold it open like this, and that's how we fill it with fluid, okay? And still our water. All right. We can bring this into the room or over the sink where we have filled it, and we've got to prime our tube, okay? Shoot, I lost my cap. Okay, so see how I primed it? So now I'm not going to be able to get it back. Because we don't want to instill any air into their intestines, okay? That just causes more pain. Let me see if I can grab my cap that I dropped. Okay, so we're going to have that all ready when we enter our room and do our entrance routine. And I'm going to say, okay, so I would say, do my entrance routine. Hi, Miss Hoffman, I'm Lainey. Let's say she's covered up. I have her uncovered from before. I'm Lainey Voss, and I'm from College of the Washitas, and I'm going to be your student nurse today. Could you give me your name and date of birth? And I would also ask her about allergies and her level of pain. Your doctor has ordered that I give you an enema today. So first, before I had entered this room, I'm going to check the doctor's order. We don't want to insert a tube into someone's rectum that doesn't have it ordered. They'll be very upset, right? It's very invasive. So always check your order to make sure that you have the right patient, the right procedure, the right fluid, whether it's a retention enema, that's an oil enema, hypertonic, or soap sud enema, or fleets, okay? Depending on what they're having done or what their problem is. So I'm going to ask her if she understands the procedure. If she doesn't, I'm going to explain it to her. You're having this problem with constipation and pain, and you haven't been able to have a bowel movement because you're full of stool. So we're going to instill this fluid into your, I'm going to put a tube into your rectum and slowly insert some fluid. And I'm hoping that you'll be able to hold it. And if you can hold it for 5 to 15 minutes, then you'll have a really good bowel movement, and that pain should go away and into your bowels, okay? It may cause a little cramping, so while I'm doing it, if you start cramping or having any pain, just let me know. I'm going to stop. I'm not going to pull the tube out, but I will stop and have you take some deep breaths and we'll wait until that pain passes, and then I'll go slower, and we'll try to finish instilling the fluid, okay? I need you to turn into the side position, so I put my patient in the Sims position, okay? And I would move her bedding out of the way, okay? We're dealing with feces, and we don't want to have to change her entire bed to do this. So you could use a bath blanket to cover her if she had people in the room or she really needed to be covered. Otherwise, you have provided privacy, and it's just you and the patient in the room, okay? So I need your help. You know, always make sure that the bed is up to your level. We'll turn, this mannequin doesn't turn very well. So I'm going to turn you on your side, and I want you to bring in your knee towards your chest for me. Okay, good. All right, so I've got them on their side. I'm going to put some absorbent pads down to protect their bed, okay? Especially if they're elderly, because they don't have that good sphincter muscle, so they're probably not going to be able to hold it, okay? All right, I'm going to talk to the patient about, I need to ask you a few questions. Do you have any problems with hemorrhoids or fissures, any tears in the rectal area? No? Okay, so I'm inspecting the area. If it was dirty, I would clean the area while I was here. Inspecting it myself really good to make sure I don't see any hemorrhoids or tears or any bleeding in that area. I also need to ask you, Ms. Hoffman, do you take any cardiac medications or blood pressure medications? Because if they do, they could have a vagal response when we do this procedure, which means their heart rate or their blood pressure can fall. And if they had that response, they're probably going to complain of being dizzy, feeling like they're going to pass out. Maybe they lose color, break out in a sweat. So if any of that were to happen, we would stop the procedure immediately, put them back in the good position on their back, and check their blood pressure and their heart rate, okay? So if this patient tells you, yes, I take cardiac and blood pressure medications, I need you to check their heart rate and their blood pressure before you start the procedure. So we know what it is before we start it, okay? All right. Ms. Hoffman, after we do this procedure, would you like to use the bedpan or the bedside commode, or do you think you could walk to the bathroom? Depending on their age, that'll help you decide which one you need to use, okay? You would like to go to the bathroom. I would assist you to the bathroom. Blake might want to use the bedside commode, okay? The older the patient, the harder it is for them to hold to walk to the bathroom. So most of them prefer the bedside commode because they're still sitting in that natural position to use the restroom. Most people do not like to use the bedpan because it's hard to use the bathroom in that position in the bed. But some of them have to because they do not have a sphincter muscle and they cannot hold it any longer. So have that ready, have that decided before your procedure, okay? All right, so I have this next to be ready. It has to be 12 to 20 inches above the patient. I have this, it's already lubricated. I would use extra lubricant, a water-soluble lubricant like KY. I'm going to insert it 3 to 4 inches into the rectum. I'm going to tell my patient, okay, Ms. Hoffman, are you ready? I'm going to insert the tube into your rectum. Can you take a deep breath for me? Okay, and as you exhale, I'm going to enter. I'm going to go in towards her navel. Okay, aim my tube towards her navel. I shouldn't have any resistance when I'm putting the tube in. Okay, if I do, then I need to try to push past it gently, never with force, okay? If I'm still hitting a brick wall, come out, see, inspect your tube, see if you have any stool inside your tube. That generally will mean you have a fecal impaction. So we would stop right here and take care of the fecal impaction. I'll talk about that again in a moment, okay? In your checkoff, our mannequins, we cannot instill the fluid into the mannequin. So once you've got in the 3 to 4 inches, you're going to hold on to the tube and then undo your clamp and start instilling the fluid slowly. It has to be over 5 to 10 minutes, okay? 1,000 over 5 to 10 minutes. If you go fast, they have pain and cramping, okay? All right, so when you're checking off with us, you'll take this back out, and I want to see you control it into the bedpan, okay? So take the clamp off, then start using your hand, okay? This is how we do it in the real world. It is hard. We have slippery gloves on. It's wet and it's lubricated. So it's very hard to control this clamp, okay? So by the time you got this clamped, you've instilled 1,000, okay? It goes by that fast. So I want you to control it by just releasing it and clamping it, okay? And you're checking in with your patient. You're watching how fast it's going down the bag, looking at the clock, and checking in with your patient. Ms. Hoffman, are you still doing okay? Are you having any pain or cramping? If she says, oh, I'm having so much pain, it's cramping really bad, stop. We're going to stop. We're going to clamp this off. We're not going to pull the tube out. Instruct her to take some deep breaths. Breathe in through your in through your nose, out through your mouth. Do that a couple of times for me. Let me know when the pain subsides. If we have stopped, it should subside, okay? Then we can start again. When we start again, we're going to go slower this time, okay? Because that's probably what caused the pain and cramping. We were going too fast. Hopefully, we'll be able to instill all of the fluid. After we do that, let me try to get my clamp. What to do with these gloves. Okay, I'm going to come out with the tube, Miss Hoffman. I come out. If I think I'm going to need, if he has ordered enemas until clear, and I think I'm going to do this more than once, I'm going to put my cap back on it and hang it up, okay? If not, if this is the only one I think I'm going to do, I can put my glove over it like this, okay, and throw this whole thing away, all right? Now, let's talk about, if this was a younger person like you, I would say, okay, I'm going to roll you back on your back. I'm not really going to do it though. I'll roll her back on her back, put her side roll back up, give her her call-out, and say, I want you to try to hold it as long as you can, up to 15 minutes. But if you can't hold, hold it just as long as you can and call me and I'll help you to the bathroom, okay? When we help them to the bathroom, we've got to instruct them not to flush it because we've got to look at the color, consistency, the aroma, the amount of stool, okay? If it was in the bedside commode or our bedpan, to put a patient on the bedpan, they're in this side position. Do y'all see this little groove right here? This groove goes with their groove, okay? This crack to this crack. And we put it up like this against our patient, and then we instruct them to roll over on it, okay? And I'm not going to do it all the way, but I would roll them back over on it. Now, is this a good position to have a bowel movement? No, what I need to do, we would sit them straight up, okay? We want them to be in the most natural position on this bedpan that we can provide so that they can have a bowel movement. If it's a young person like you, I could leave the room and give you the call out and say, I'm going to give you some privacy. Call me when you're done. If it's an elderly person, guys, don't leave them. It's unsafe to. It'll be a mess. They may... it's probably going to be immediate. Their results are immediate. You're lucky if you get to instill the entire amount before it starts coming back out on you. And as soon as you pull that tube out, most of the time, so comes the fluid. Okay, they cannot hold it. Okay, all right. To get them off of the bedpan, I would say, can you roll back on your side, Miss Hoffman? Roll back over and grab that. And I'm holding the bedpan down. Okay, I'm holding it down. Otherwise, it flips up like this with her, and we've got watery stool everywhere. Okay, so hold it down. Now, because she is an elderly person, I'm going to have my supplies with me to clean her. I'm going to take this and all of our equipment in the room are made so that we can wash them. Okay, all of our chairs and what am I trying to say? Benches, all the furniture in the room are now washable. Okay, so I'm going to cover this just for her dignity, or in case any family members come in while we're doing this. This looks a lot better covered, doesn't it? Because I don't want to leave her side, because I'm going to clean her. I'm going to put this in the chair covered, and then I'm going to clean her really well, okay? So I'm going to clean her, take care of this. Now I'm going to get her back in a good position, okay? Put the side roll back up, and then take this to the bathroom, okay? Always observing it for the color, characteristics, the aroma, the amount, okay? Okay, now let's do some troubleshooting. So let's say I'm doing this, and I'm in the middle of the enema, and the patient says, oh, I feel like I'm going to pass out. I'm feeling really sick to my stomach, and I'm feeling really shaky. What do you think is happening?
Blood pressure's dropped.
That's right. So what are we going to do?
We're going to stop.
We're going to stop
and check.
Pull the tube out, clamp it off, pull it out, stop, put them back on their back, and check their blood pressure and their pulse, okay? If it is lower than what you assessed to begin with, then we're going to call the doctor, okay, and ask him how to proceed, all right? but we're not gonna continue because, we don't want a really low blood pressure or heart rate.
Take this.
Let's say, did we talk about this? I'm forgetting, I've done this so many times now, what we've talked about. Let's say I have it inserted and no fluid comes out. Did we talk about that? Okay. No fluid comes out. The first thing I want you to do is consider that you don't have this high enough, okay? So I want you to raise it up a little higher and then observe, is the water coming out now? If it's not, then I want you to think, maybe I have a fecal impaction, okay? So I want you to try to insert it a little further with no force. It should easily move, okay? If there's any force or you feel you're hitting a brick wall at all, you've got a fecal impaction. So we're going to stop, take this out. Ms. Hoffman, I believe you have a fecal impaction. What that means is you have some hard stool that's preventing me from doing this procedure. So I've got to remove it, the stool, before I can give you this enema. And I'm going to do that with my finger, okay? I'm going to lubricate my finger really well, and we're going to slowly remove it, okay? I know it's going to be uncomfortable. If it is severe pain, I will stop. You just let me know. Okay, so I would have her in this position. I'm going to lubricate my hand really well. I would have this rail out of my way. I'm going to have a bedpan on the bed, and I'm going to, with one finger only, do not use more than one digit, and do not use your entire hand to remove this. This is very painful, so we'll slowly, a little at a time, dig away at the impaction. Sometimes we're able to remove it all ourselves, and sometimes we're able to remove enough that we can continue our procedure, okay? So just remember that, lubricate your hand really well, just use your index finger. Check in with your patient. If it's causing them severe pain, we've got to give them rest periods, okay? And then if it's taking a long time and it's a lot, we need to call the doctor and ask how to proceed, okay? So I went over those two. I think that's it. I think that is the entire thing. Because I went over what all, okay, now there's one more thing. And I told the others, that when I videoed it, I would not forget to do this. When you're asking all the questions, you've got to ask your patient. When you're asking them, have you had any trouble with your bowel before? Do you take any cardiac medications or blood pressure medication? Do you have hemorrhoids or fissures? We're also going to do an abdominal assessment, and I know we haven't talked about how to do that yet, but you're going to do that with your stethoscope. First, we would look at their abdomen, okay? Our landmark is our belly button. We have upper quadrants and lower quadrants. We always look first. Okay, and we're looking for any distension, bloating, any masses. If we have little bumps somewhere, that's a mass. So we're going to look at that first. Then we're going to listen. We would take our stethoscope and our ears go forward if we have them in correctly. Okay? If you'll tap your bell, you should hear a loud noise in your ear, okay? If not, turn it and see if you hear it then, okay? I had mine correct already. So I'm going to place this on that lower right quadrant and listen. I should hear, if the bowel sounds are normal, I should start hearing them within 5 seconds, 5 to 30 seconds, okay? If they're really constipated, it may be hypoactive and I may have to listen, you know, a minute or 2 minutes. If you don't hear anything, if you're not hearing anything, you have to listen 5 full minutes before you can say someone has absent bowel sounds, okay? And just because they're absent here doesn't mean that they're not active up here. So listen to every quadrant, okay? Maybe you have bowel sounds here and here, but you don't hear any over here in the left upper quadrant. Listen to every quadrant. But if you don't hear any, listen 5 full minutes. If you still don't hear any after 5 minutes, you go get a second nurse. I'd say, Courtney, I don't hear any bowel sounds on Miss Hoffman's left upper quadrant. Would you listen? She's going to listen for 5 full minutes. And then if she doesn't hear them either, we're calling the doctor, okay? Because that could mean they have a bowel obstruction, and that means they need surgery, okay? So we need to call the doctor right then, all right? So we're going to check the bowel sounds before we do the enema, because it should improve after we do the enema, okay? We're increasing peristalsis and moving, we're having that bowel movement. So if they were hypoactive and you had to listen 1.5 minutes or 2 minutes after you do the enema, it should be faster. It should be 1 minute or 30 seconds that you start hearing bowel sounds, okay? So make sure you assess that before, when you're asking all your questions, go ahead and do your assessment with that, okay? And remember the order in which we do it. We look, we listen, and then we palpate. You aren't going to be palpating. We'll do that when we do physical assessments. But just remember, we start at the right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant, okay? It's clockwise, that's how we do it, okay? And I think that's it. Now I went over the